Para finalizar el simposio, le vamos a pedir al doctor Hariharan que nos dé su conferencia de cáncer después de trasplante. El doctor Hariharan hizo su estudio de medicina y medicina interna en Bombay, en la India, y sus estudios de nefrología en la Universidad de Cincinnati. Actualmente es profesor titular de medicina de la Universidad de Pittsburgh y es director del programa de trasplante renal y trasplante riñón-páncreas en ese centro hospitalario. Y es una autoridad internacional reconocida en el tema del trasplante renal.
Good evening. You know, when you are in Rome, you are a Roman. I'm in Chile, I'm a Chilean. So this is a beautiful statue. I took the picture a couple of days back. It's a spectacular, I mean, my wife and I are having a great time in this city. It's such an enjoyable place, such a spectacular city. I've been asked to give a talk on kidney tumors in renal transplant recipients. This is a topic I encounter. I'm not an expert. So if you have all the questions, ask the experts, the oncologists. They are the one who can give the answers to that. So if you look at immunosuppression over years, the newer immunosuppressive medications have markedly reduced acute rejection rates, but we still have problems. Problems in terms of chronic rejection, whether a T or a T cell or antibody mediated, infections such as BK virus nephritis, which I'll be talking on Wednesday. Recurrent disease is still a problem. And the most important one is the death with a functioning kidney. Cardiovascular problem is largely contributing to that, but post-transplant malignancies really becoming increasingly an important issue which we deal in our transplant patients. I'm going to cover a variety of topics. Let me, in the interest of time, I'll go through those very quickly here. I'm going to run about 3 cases. These are real cases. This is a 44-year-old Caucasian female who underwent a kidney transplant successfully, doing very well, did very well for first 6 months, was admitted with the enlarged cervical lymph nodes. Our usual worry is the lymphoma, but anyhow, she had a living donor transplant, doing very well from a transplant point of view, maintained on standard immunosuppression, and the biopsy showed malignant melanoma. The donor did not have any melanoma. We extensively evaluated the donor, and complete skin examination was negative. She had a PET scan which showed a generalized metastasis all over. We couldn't identify the location of the lymphoma. Unfortunately, this young lady succumbed to the disease in a matter of few months. By about 1 year, she succumbed to this extensive metastatic melanoma. The second case, 25-year-old Asian man admitted for weight loss and weakness. IgA nephropathy is a cause of disease, and point to note is the EBV serology was donor was positive and recipient was negative, conventional standard immunosuppression, and this patient presented with an extensive lymphadenopathy, and the diagnosis is very obvious. Patient had a PTLD, which is a B-cell PTLD, CD20 positive, and the serum EBV PCR was negative. Patient received a combination of rituximab, a reduction of immunosuppression, and completely responded to the treatment, also mounted immunoglobulin antibody for EBV. Third is a 70-year-old gentleman admitted with diarrhea. And many times we do a variety of tests for an unnecessary reason. I always say we do the test for we ask for the right test for the wrong reason, and that's what happened in this case. And this patient was doing well from a transplant point of view, and historically on cyclosporin, Imuran, and prednisone. And essentially what he found out, because of the diarrhea, someone asked for an abdominal CT. It doesn't help, but abdominal CT picked up a mass in the right kidney, native kidney, and it turned out to be an adenocarcinoma, and the right nephrectomy, kidney nephrectomy was done, and patient did very well. So I've given you 3 spectrum. One was melanoma, one of the PTLD, and the third one is the native kidney tumor. Let's address this topic, which we encounter very frequently in our clinical practice, from evaluation to the post-transplant management. The first thing you have to know, what is the incidence of cancer in kidney transplant recipients? The best data comes from Australia. The advantage of Australia is they collect the data on various aspects in a very granular fashion. and they collect the data on transplant and also look at the annual incidence of variety of conditions, including skin cancer, including various cancer. So if you look at the Australian population, any cancer is approximately about 4 or 5% at the end of 10 years or 15 years or 20 years. If you look at skin cancer, it's extremely high in Australian population, which is understandable because of the severe ozone depletion and population pretty much lives around the coast. Then if you look at non-skin cancer in Australian population, is also pretty high. It's up to, I would say at the end of 10 years is about 15% at the end of 20 years. These are all kidney transplant recipients. And there are patients who have a combination of both, and this is something you have to keep in mind, that the overall incidence of any cancer can be as high as about 80% at the end of 20 or 30 years after transplantation. I do understand these are large number of patients in Imuran, but still overall incidence of cancer is very high. We don't have such a fine data in other registries, including United States, but this is the best we can go by. Is the incidence of cancer higher in transplant population than in a non-transplant population? There are a lot of beautiful studies have been done. I'm giving you an example which was published by Bert Kasiski in AJT in 2004. What you have to keep in mind, if you look at a colonic cancer, lung cancer, stomach, they're about a little bit higher. And melanoma is definitely higher. It's about 5 times higher. And some of the hepatobiliary cancer and cervical cancers are higher. These are mainly oncogenic virus-associated cancer. But if you look at native kidney cancer, is 15 times higher than the general population, and PTLD and Kaposi sarcoma is really substantially higher in transplant population. So all you have to keep in mind is skin cancer, kidney cancer, and PTLD. These things are very high. That's the reason I represented these 3 topics in the case I discussed before. There's a paper published last year by Dori Segev from Johns Hopkins. He does a lot of epidemiology work, fantastic work, and he looked at the cumulative incidence of cancer from 1987 to 99 and 2000 to 2008, and he found out the incidence of cancer is definitely on the rise the years after transplant. And this is also compared to if you look at the death, graft failure, and retransplantation, even after adjusting for all those things, is definitely, that also gives the distribution. So the bottom line, according to his paper, is cumulative incidence of cancer has definitely increased in recent years, looking at the graph. And the higher incidence was seen in older recipients, as we tend to transplant many older patients. And non-Hodgkin's lymphoma you see in extremes of ages, younger individuals and older individuals, higher incidence of colorectal cancer, and lung cancer is definitely high in thoracic recipients. And breast and prostate cancer incidence is very similar to the general population. And he did not do a further analysis much on the kidney cancer, and skin cancer was not included. So if you look at the solid organ tumors, including lymphoma and colorectal was very, very high according to his analysis based on the database. Then the question comes, why is the cancer high in transplant patients? It's intuitive to keep in mind, we give immunosuppression. When we give the immunosuppression, patients cannot protect themselves against oncogenic antigens that results in a cancer. So there are general risk factors which are very well known. It's okay? Yeah. General risk factors which you very well know, and immunosuppression, we talked about the oncogenic virus, and all these things produce cancers. And immunosuppression also, affects the immune surveillance and the direct effects of immunosuppression. All this combination of elements leads to higher incidence of cancer in transplant population. Let's look at specific immunosuppression. One of the old player, Imuran, which we still use occasionally, not very frequently in newer transplant, it's a very strong inhibition of the DNA repair. That is the reason the incidence of skin cancer is extremely high in patients on Immuran. If you calculate, you estimate, or you do some skin biopsy and look at the Immuran concentration under the subcutaneous tissues, extremely high, and that's the reason the skin cancer is extremely high with this therapy. What about a mycophenolate mofetal and cancer? Mycophenolate mofetal to some extent have a protective effect against the cancer, and this has been well described in various studies, including this meta-analysis. And based on this meta-analysis, they found there is no higher incidence of cancer in patients with the mycophenolate mofetal therapy. And what about the cyclosporin? Essentially, calcineurin inhibitors have a higher chance of developing cancer. This is well described in a variety of papers. I'm giving you a sample here from the French group published about 15 years back. They looked at the incidence of cancer with a normal dose of CNI or cyclosporin and low dose of CNI, that is cyclosporin, and the incidence of cancer was much higher in the normal dose versus low dose. This has not been replicated in recent years, but because the graft survival is better with the calcineurin like tacrolimus, with tacrolimus therapy, this kind of analysis has never been done to see that CNI can aggravate cancer. There is also a lot of molecular basis diagnosis which has been shown that the skin cancers can be definitely high. I mean, all these cancers can be high in patients who receive CNI therapy. So I talked about the Immuran. I mentioned about mycophenolate mofetal, then mentioned about CNI. What about the new drug belatacept? Belatacept has been approved for the last few years. Its use has been limited because of the logistic issues and the expense involved in that. But the incidence of PTLD per EBV status is very high in belatacept status, which means patients who are seronegative have a higher chance of developing PTLD with belatacept infusion. So there is a black box warning. If a recipient is seronegative for EBV, you cannot use belatacept. And these results have come from the multicenter trial as well as the phase 2 trial. They pooled all the data together. So the incidence of PTLD is extremely high comparing to recipients who are seropositive. What about sirolimus? Sirolimus is a very strong anti-angiogenetic agent which can regress cancers. And the first data came back in New England Journal of Medicine in 2005 in 15 recipients who developed Kaposi sarcoma. They were switched from cyclosporin and Cellcept to sirolimus, which resulted in a complete regression of this tumor. So that's the reason sirolimus is a very popular agent for administering in transplant recipients who have developed solid organ tumor. Is there a further data available? Yes, there is data available. Looking at the US registry, Myron Kaufman did this analysis, and patients who received TOR inhibitors alone, TOR inhibitors with CNI, and or patients who received cyclosporin and tacrolimus, he looked at the de novo malignancy and de novo non-skin malignancy, and what he found out, the incidence of tumors are much lower in patients who receive TOR inhibitors alone. But unfortunately, this agent is not sufficient to prevent allograft rejection. Most of the patients, if at all they receive TOR inhibitors, they combine today with MMF or occasionally with CNI. The incidence of tumor is much lower compared to this. So based on this anecdotal reports, experience from Kaposi sarcoma, and the Europeans did a very good job on doing a very prospective trial on using rapamune in the prevention of skin squamous cell carcinoma. So to be brief, they enrolled over 129 patients. Half of them, these are all stable patients, and essentially they had 49 patients with a 1-year follow-up and 51 control, and they followed them for the incidence of tumor. This data was published in 2012 New England Journal of Medicine. What they found, the incidence of freedom from developing de novo cutaneous squamous cell carcinoma was much lower with sirolimus therapy comparing to calcineurin inhibitor therapy. The incidence was 22% versus 32%, and it was statistically significant. They also looked at the sub-analysis on patients who had freedom from developing de novo cutaneous squamous cell cancer These are patients who had a single cancer before. What are the chances of developing subsequent cancer? Here also they found out sirolimus was much more effective than calcineurin inhibitor therapy. But the problem with giving sirolimus, the incidence of rejection is high. When you combine with CNI therapy, the nephrotoxicity is high, but still there is a definite utility of using sirolimus in reducing the frequency of skin cancers. So we do use sirolimus or convert patients to sirolimus in patients who have multiple skin cancers, and it is definitely effective in helping them. So based on the tumor wrapper study, the conclusions were switching patients from CNI to sirolimus resulted in lower incidence of de novo squamous cell cancer, delayed occurrence of cancer, and according to their data, similar incidence of rejection, but the side effect profiles were much higher, like hyperlipidemia, proteinuria, wound problem, even pneumonitis. All these things were definitely higher. The risk-benefit ratio was decreased at lower dose of sirolimus. You don't need a very high dose of sirolimus to reduce the frequency of skin cancer. You need to keep the level anywhere between 2 to 6 nanograms per ml. That is efficient enough to prevent skin cancers. And with the anti-tumor effect was more pronounced in subjects with prior occurrence of skin cancer. These are patients who are prone to develop skin cancer. So in those patients, it was really effective. But I have to, in my personal experience, I have to also tell you, if you have a patient who has a skin cancer, if sirolimus helps, for any reason you stop sirolimus, they have a real rebound effect of multiple skin cancers after the discontinuation of sirolimus. So moving on to the next one, which is still important, is very important, is the native kidney cancer after transplantation. This is the patient of mine, who, different patient who came with some abdominal pain, and he had a little polycythemia, and as you can see, his native kidneys are already ballooned up, and he had a definite adenocarcinoma, and he did respond well to native nephrectomy. This is the real problem. As our patients are getting older, and our patients are waiting on dialysis for a very long time before undergoing transplant, we are seeing patients who are coming with native cancer at the time of evaluation, or between evaluation and transplantation, or after transplantation. So what is the risk for cancer according to the Australian registry since dialysis or since the time of kidney transplantation on primary disease? So they published this in JAMA a couple of years back, and it's in 2006. There is a follow-up paper also, and essentially what they found, that time since dialysis or transplantation, time since dialysis did not make much difference. The incidence of native cancer was roughly the same, but the time since, I think this arrow is not working, I'll try this one. The time since transplantation was much, much higher in terms of the native kidney cancer. Once again, this particular data may be spurious because of the less number of patients and the limited follow-up. But keep in mind, as your patients are waiting longer on dialysis, we are going to see higher number of patients with native kidney cancer. One of the important problems we are seeing now is post-transplant cancer, donor transmission versus host-derived. It's not always easy to differentiate. Let me give the little classification here. Donor transmitted is a specific where you have an unknown lesion and you transmit that. It is present in the donor at the time of transplantation and likely to manifest within first 2 years after transplantation. It is a classic what is described as a donor transmitted cancer. The donor derived or a donor origin is not present in the donor at the time of transplantation, so may manifest any time after transplantation. And the last category is de novo cancer, which is host origin, may manifest any time in transplant individuals, either in the transplanted organ or other organs, and the incidence rises with the time post-transplantation. Okay? What about one of the real problems we face in an evaluation is when patients have a history of cancer. It's easy to say someone has got a skin cancer, I don't have to worry about it. We see some women after about 5, 10, 15 years after a breast cancer, they are pretty much cured from the breast cancer or from a lymphoma. They are very comfortable. This data is not clear out there in terms of whom we can transplant, whom we cannot transplant. This is more of an opinion paper. There are a variety of opinion papers available. I picked up the risk category. The risk category is no significant risk, minimal risk, or low risk. So someone who's got a skin cancer, in situ cervical cancer, vocal cord cancer, the risk is very, very minimal. One can be very comfortable in accepting these patients for transplantation. What about other conditions here? Solitary renal carcinoma, which is very, very small, primary CNS lesions, low-grade CNS tumor, and papillary thyroid carcinoma. The incidence is there, but they are definitely very, very low. And there are some conditions which are intermediate risk. The range is very, very high, it's 1 to 10%. And you have to look at the high-risk patients like the breast cancer, which is active, colonic cancer, which is active, and certain kinds of leukemias and all this thing. So this area is not clearly defined. These are opinion papers, gives you a large range. So one has to be very practical in approaching a patient with an existing cancer. The way I look at it, if I see a patient who has a history of cancer, go specifically to find out what the cancer is. From the National Cancer Database, you can find out what is the current survival rate for that condition at the end of 5 years and 10 years. So you will have that answer. Once you have the answer, you kind of risk modify the recipient and say, what are the chances of this patient surviving at the end of 5 years in dialysis? It's very scary to say the renal failure patient mortality is much, much higher than cancer by and large. So we always find out the risk for developing, someone dying on dialysis at the end of 5 or 10 years, let's say, is 20 or 30%, and the risk of surviving with that kind of cancer is about 95%. It's easy to argue to go for a transplantation. That is, you as a clinician or we as a clinician can make the decision, but many a time the insurance they see only black and white. They say this patient has got a smoldering myeloma, I cannot transplant this individual. We will not approve this patient. So we have to literally fight. So this area is completely evolving. If you have any young investigator want to do further research on this, this is the area I would like to really focus on that. The waiting time for transplantation, and as I mentioned before, the outcome of patients with cancer is far better than that of dialysis. And there is no need to delay transplantation for certain cancers. Someone who's got a prostate cancer at the age of 65, very low grade, patient is going to live for another 20 years. That patient on dialysis will have a very poor prognosis, so you are better off transplanting him and tackle the prostate cancer. And there is no wait time required for skin cancer, most of the brain cancers, and most of the, I wouldn't say all brain cancer, but majority of the brain cancer and certain prostate cancer. Lymphoma treatment has completely changed in the last 20 years or so. I mean, lymphoma can really be cured, and once they are cured from lymphoma, many of the patients can be treated very well. Most of the breast cancers, I give a range here, if they are free from breast cancer after treatment for 1 to 5 years, we have a reasonable prediction how well those patients are going to do. So it's reasonable to wait for that much period of time before submitting for a transplantation. And also remember, there are quite a few solid organ tumors, they do very well. So we are increasingly seeing patients with the history of prior cancer, and this data is definitely evolving, and we have to keep up with our time and say accept many of these patients for transplantation. So I covered a variety of topics. I started off with 3 cases. I've given you the overall prevalence and variety of prevalence of skin cancer from the Australian registry. I also provided which cancers are higher in transplant population. I talked about the pathogenesis. I specifically focused on the skin cancer, which is an increasing problem in our recipients. I'm sure also in your recipients here in Chile. And it's really a global problem. And also talked about how much the patient should wait, what kind of organs we can accept from a patient with a history of cancer. And that area is a little bit murky. As I said, it is definitely evolving. So in conclusion, incidence of cancer continue to increase. As we are getting older, our patients are getting older, our patients are waiting for a long time, this incidence is not going to decline. And the pathogenesis is based on oncogenic virus. I didn't have much time to dive deep into that. And is definitely related to immunosuppression. any immunosuppression we give, we have side effects. One of them is cancer. And types of immunosuppression. As we increase the potency of immunosuppression, it proportionately increase the chance of infection as well as tumors. And the recipient age is definitely an important factor. Older patients definitely have a higher chance of developing skin cancer, any cancer. TOR inhibitors, I already mentioned, are very effective in preventing and definitely delaying. It will not completely cure, but it will improve the quality of life substantially. Incidence of native kidney cancer is definitely rising in end-stage renal disease, or more so in transplant recipients. And increasingly, as our donors are getting older, they may have a history, so one has to be very careful in looking at potential disease which can be transmitted. Recently, we had a patient who, after the transplant, we came to know that the donor had an appendicular tumor of some kind. When we went back and told the recipient, they said, I don't care, I want to keep those organs in, you continue to monitor me. It was very localized, but these things are increasing problem in our transplant recipient. And donors with certain history of certain skin cancers, certain cancers can be transplanted very safely. Wait time for transplantation with the history of cancer continue to evolve, so one has to be very, very careful, analyze individual case with exact type of cancer, what is the outcome, then look at their comorbid conditions from the renal point of view and come out with a reasonable judgment and write a strong letter to the insurance company so that we can transplant them, okay? So I decided to root for Chile for the World Cup, so I put their flag in here. World Cup is not far away. I'm sure all of you are excited, and I'm excited too. Thank you very much for your attention.